Protocol 36 is our hypertension protocol. No new treatment within this protocol for hypertension in your patients. Just a note on hypertension, it's not uncommon, especially in an emergency setting. It's the body's natural response to stress or pain. A hypertensive emergency is based on blood pressure along with symptoms. These symptoms suggest an organ is suffering damage, such as an MI, a CVA, or renal failure. This is very difficult to determine in a pre-hospital setting in most cases. Aggressive treatment of hypertension can result in harm. Most patients, even with significant elevations in blood pressure, need only supportive care. Specific complaints such as chest pain, dyspnea, pulmonary edema, and altered mental status should be treated based on specific protocols and consultation with medical control. All right, Protocol 37 is a hypoglycemia diabetic emergency protocol. No real change from your current protocols in treatment of your hypoglycemic or hyperglycemic patient. Protocol 38 is our hypotension shock adult protocol, and it's broken down between hypovolemic, cardiogenic, neurogenic, and septic shock. Your pressor of choice is dopamine still, and of course your saline boluses. Protocol 39 is a hypotension shock pediatric protocol, and first thing we're going to look at is our adequate ventilations and oxygenation, but we need to make sure that our patient is actually hypotensive. So hypotension age-specific vitals, we get that by the systolic blood pressure less than 70 plus 2 times the age equals poor perfusion and shock. So 70 plus 2 times the age, if the systolic is less than that number, we have a pediatric patient with poor perfusion. We're going to look at our adequate ventilations and oxygenation. If they are adequate and trauma is present, we're going to exit to the multi-system trauma protocol. If no trauma is present, we're going to establish our IV, obtain ECG, and we do want a blood glucose analysis. Now, if that blood glucose is within a normal range or greater than 60, we are going to continue with normal saline boluses at 20 milliliters per kilogram. Repeat as needed, times 3 to the effect of a systolic blood pressure greater than that 70 plus 2 times the age. And of course, we have dopamine as a consideration at 5 to 20 micrograms per kilogram a minute IV/IO, again to maintain that normal systolic blood pressure greater than 70 plus 2 times the age. Okay, so let's take a look at lowest blood pressures by age. If the patient is a neonate or less than 31 days old, then the systolic blood pressure should be greater than 60 millimeters of mercury. If they are 31 days to 1 year, then it should be greater than 70 millimeters of mercury. And if they are 1 year and older, we use that mathematical equation of 70 plus 2 times the age in years to get that systolic pressure. If the patient has a history of cardiac disease, prematurity, chronic lung disease, or renal disease, we want to limit our normal saline boluses to 10 mLs per kilogram and reassess for fluid overload. Okay, Protocol 40 is our nausea and vomiting protocol, and the first question we need to ask is, are there serious signs and symptoms of hypotension, poor perfusion, or shock? If the answer is yes, we're going to immediately start treating our hypotension with our normal saline boluses of 500 mLs. We may repeat up to 2 liters to obtain that systolic blood pressure greater than 90 millimeters of mercury, and then we're going to treat the nausea with our Zofran. Now, our Zofran doses are the same for our adult, 4 milligram IV, IO, IM, and the advanced provider may repeat times 1. For our intermediate providers, they can treat the pediatric patient as long as they're over the age of 6 months old with Zofran at 0.15 milligrams per kilogram IV or IO. If the patient is having abdominal pain, we're going to exit to the pain control protocol, Protocol 7. If no abdominal pain is present, we want to establish an IV at a TKO rate, and if the patient improves, transport to the hospital. But if no improvement, we can administer normal saline boluses, 500 mLs, and then 150 mLs per hour. And for the IMP level providers, the boluses will be 20 mLs per kilogram to obtain and maintain a BP that is age specific. Protocol 41 is our newborn neonatal resuscitation protocol, and this protocol basically mirrors the inverted pyramid of neonatal resuscitation. It also discusses airway suctioning to clear amniotic fluid and meconium aspiration for our paramedic providers, and we are going to cover meconium aspirators in the skills portion of this protocol training.